It was interesting that people latched on to a lab result that came from the case study, which, as it's defined, it's a patient with cryoglobulinemia. Cryoglobulinemia is classically, in most American settings, either a side effect of hepatitis C, or monoclonal gammopathy, or autoimmune disease. So you search for that, you search for that, and you search for that, and it was not found. And that's suggesting that what it really is a reflection of the immune stimulation brought on by the Gaucher cell. Most patients with Gaucher's have very high levels of immunoglobulin, the protein that that protect ourselves from various bacteria, infectious organisms, and other potential invaders. However, the subsequent assessment of the patient also showed that these not only were high, these immunoglobulins, but there was a clonal population, meaning a potential thought of a malignancy like myeloma. When the Gaucher was treated, this was not the case. It turned out to be a reflection of the immune stimulation of the Gaucher's disease. So all in all, I think you're dealing with many red herrings. Now, are there reverse red herrings? Can you actually get a patient you think is Gaucher's and actually not? And that can happen because the diagnostic finding in Gaucher's for pathologic bone marrow assessment is the classic tissue paper cell called the Gaucher's cell. Very big, looks like you crumpled a piece of tissue paper with it and put a nucleus in it. Well, it turns out that cell is also reflective of an immune stimulatory effect and can be seen in TB, can be seen in myeloma, could be seen even in joint replacements sometimes, and therefore you can assume you saw it and therefore it was Gaucher's case. That's not necessarily the case. And in Gaucher's patients, you can have atypical cells with really very few of those cells, or you sampled where there are atypical Gaucher cells and you don't see them. So if you've got the absolute triad, or you're very suspicious, look for the enzymatic testing and the dried blood testing. First is the classic triad that we spoke about, which is especially in pediatric patients, bone pain, spleen enlargement, and low platelets. That's the classic Gaucher's triad. But as an adult, I believe this algorithm that was defined by Pram Mistry and Maria Cappellini is probably the next best thing in terms of sensing it. If they don't have thrombocytopenia, if they absolutely don't have the classic bone pain, and you may not get it till your 7th decade sometimes, identifying splenomegaly and then screening appropriately, I think, is the best approach clinically we now have. But the importance there is it's not difficult. It's a blood spot test. Call your local lab, ask for the appropriate filters, teach your lab people how to place it on the filter, send it in, and get the diagnosis. Albeit a lot of them will not be true Gaucher's patients, but will be able to then get the more specific lymphocyte enzymatic testing or subsequent testing to prove it. But that is probably the best way at the present time.